sir, Dr. Anuja Patil ma'am, to conduct the upcoming masterclass. Dr. Shravani will be presenting the case for this session.
Good morning, everyone. Good morning, ma'am. Good morning, sir. Shall we start, sir? Hello. Good morning, everyone. A 64-year-old male agriculture laborer by occupation hailing from Ponduru came with the chief complaint of drooping of both eyelids since 1 year and complaint of difficulty getting up from squatting position since 10 months. History of present illness. Patient initially noticed drooping of both eyelids 1 year ago, which was insidious in onset, gradually progressive, symmetrical, non-fluctuating, painless, and no aggravating and relieving factors. No history of double vision or blurring of vision. No history of difficulty swallowing food and nasal regurgitation of food. Around 10 months ago, patient noticed difficulty getting up from squatting position, insidious in onset, gradually progressive, symmetrical, non-fluctuating. Patient initially required little support to get up from squatting position, but since last 6 months, patient is taking support of both his hands kept on the floor to get up from the sitting down position. No history of slippage of chappals. Patient is able to lift his neck above the pillow. Patient is able to comb his hair and grasp objects from above the shelf. Patient is able to roll from side to side on bed. No history of thinning of limbs. No history of stiffness of muscle, stiffness of limbs or flabbiness of limbs. No history of visible twitches over the limbs. No history of any involuntary movements of muscles. Patient is able to feel clothes over his body and perceive hot and cold water while bathing. Patient is able to perceive mosquito bites over his both upper limbs and lower limbs. No history of band-like sensation over the trunk. No history of electric shock-like sensation on bending the neck. No history of swaying while bathing and able to do his daily activities with his eyes closed. No history of tremors while reaching objects. No history of seizures. No history of any rash or muscle pain. No history of loss of appetite or loss of weight. No history of dark colored urine. Patient is able to smell well. No history of difficulty perceiving color and no history of blurring of vision. Complaint of drooping of eyelid, history of drooping of eyelid present since last 1 year. No history of double vision. Patient, no history of loss of sensation over the face. No history of deviation of mouth and slurring of speech or drooling of saliva. No history of difficulty hearing and no history of ringing sensation in the ears. No history of nasal regurgitation of the food and nasal twang of speech and hoarseness of voice. No history of difficulty moving head side to side and shrugging shoulders. Patient is able to move food bolus around his mouth and able to move tongue in all directions. No history of spillage of food while eating and no history of unsteadiness while walking. Patient is able to negotiate through narrow pathways. No history of increased frequency of urination or urge incontinence. No history of difficulty voiding urine and dribbling of urine. No history of involuntary passage of stool. No history of abnormal sweating and no history of giddiness after waking up in the morning. No history of any fever, neck stiffness and vomiting. Past history, patient had surgery to his left eye 2 years ago in view of pterygium and cataract. Not a known case of hypertension, diabetes, coronary artery disease, stroke, chronic liver disease, chronic kidney disease, epilepsy and thyroid disorder. Personal history takes mixed diet. Bowel and bladder habits are normal. Sleep and appetite is normal. No addictions. Family history, patient is born out of non-consanguineous marriage and no other similar complaints in any other family members. Summary, elderly male presented with pedigree chart. This is the pedigree chart. Summary. Okay. Summary, an elderly male presented with gradually progressive bilateral ptosis since 1 year and gradually progressive weakness of lower limbs involving proximal muscles since 10 months with no history with no sensory cranial nerve, bowel and bladder involvement with no significant family history. Localizing as the patient has.
And before you go for localization, basically he has only two complaints.
Yes.
One is drooping of eyelids and proximal muscle weakness in an elderly male. What is his profession?
Agriculture laborers.
Okay. So, educational status?
So he's illiterate, sir,
Okay.
can't read.
No, just you have to mention that. So you said, is there any diurnal variation?
No, sir.
No diurnal variation in both drooping of the eyelids and
And
proximal
proximal
muscle
weakness.
weakness. So, what initially what comes to your mind when somebody elderly? So you need to address that in terms of symptomatology, like any increase in with what history you will ask, because you said that there is no change, but for example, somebody is reading. So when he is reading, whether there is any increase in like double vision or increase in drooping. The drooping is symmetrical?
Yes, sir, symmetrical.
Symmetrical drooping. So is it to start with, is it asymmetrical or from starting it's symmetrical?
Yes, sir.
From starting
From
it's
starting symmetrical.
whatever history you got. And there is no diurnal variation?
No, sir.
No increase with any activity like
No, sir.
reading or...
No, sir.
No history of any bulbar symptoms,
No,
like
sir.
change in voice, nasal
No, sir,
regurgitation.
no difficulties.
Like if he
swallowing.
is talking for a prolonged period, does he have any,
Reduced to, no, sir.
like with some whatever exercise, is there any change? No change.
No.
Even the proximal muscle weakness also, there is no change. Like improvement, you have to bring out two important things. One is increasing with exercise and improvement with rest. It's not there.
No, sir.
So, okay. So, that is, we have to go initially in neurology, whatever, generally, one is for localization, two is for symptomatology and treatment. We usually consider first the treatable conditions. So, you want to say anything? She didn't mention.
No, sir. Right.
Localization, what are the possibilities?
Sir, as the patient has no stiffness of limbs or no distal muscle weakness, only proximal muscle weakness with ptosis.
No, okay,
I
in
want
general,
to consider,
because you are MD kada,
yes, sir.
so first to start with, whether it is upper motor or lower motor.
Lower motor.
So why do you think it is lower motor?
Because in upper motor neuron we see stiffness of limbs and involvement of both distal and proximal muscles.
It will be a pattern kind. So your motor, upper motor
Here
neuron,
the pattern is
anti-gravity.
proximal muscle weakness in lower limbs and drooping of eyelids.
Yes, sir.
So what comes to your mind? First possibility.
Lower motor.
Huh?
Lower motor.
Okay,
neuron.
lower motor neuron. In lower motor neuron, which
Substrate.
Sir, in the
anatomical,
order, if we
huh?
come in the order, anterior console, root, plexus, peripheral
no, okay.
nerve.
With this history at 67 years, what
It
will
could
be
be
your
muscle or neuromuscular junction.
Okay, first you think neuromuscular.
Yes, sir.
Why did you think neuromuscular? And what are the points for neuromuscular from history and what are the points against?
Actually, there is no diurnal variation or fatigability, so neuromuscular junction is unlikely, sir.
You kept it as first.
So you can't say unlikely because first we have to consider a treatable condition. So unless otherwise proved, we should still consider neuromuscular junction, especially when somebody has proximal muscle weakness and drooping of the eyelid, and progressive and late onset. Maybe we don't know and no family history.
Yes.
So one possibility is because quite significantly patients, quite a good number, maybe around 20 to 25% may not give history of this thing, but only odd. So what are the points against other than fluctuation and
Symmetrical.
symmetrical? Okay, symmetrical still can be there, but what points are against are unlikely? I don't say against. If you have drooping, what other features should be there?
Difficulty in swallowing food.
Okay, other ocular, no double
Diplopia.
vision or squint or in spite of 1 year history and there's not fluctuation. So there is no other like other ocular muscle involvement. And okay, no bulbar symptoms and no upper limb proximal weakness, only lower limb, no. So those are odd, but still my first possibility, treatable condition will be still neuromuscular junction, could be myasthenia. Or in myasthenia we have different types. So whether it's acquired or congenital myasthenia. Late
Age of
onset, so
onset,
unlike
late
most probably an acquired myasthenia. So we have, we'll discuss later then. One is neuromuscular junction, then what is the other anatomical?
Muscle.
Okay, muscle. So what are the points for muscle? What is the points against muscle?
Symmetrical weakness.
Okay, symmetrical weakness, no
gradual
fluctuation.
progression over years, sir.
So
Onset.
drooping of eyelids. Which muscle diseases will have drooping of eyelids?
Levator palpebral superioris, Muller's muscle.
No, which disease? Which disease comes to your mind? Muscle disease.
OPMD, sir.
OPMD. What is the commonest muscle disease in adults? Entrance bitta
Limb
madi.
girdle.
Huh?
Limb girdle.
No. What is the commonest muscle disease in adults? Entrance bitta. Anybody from the audience also can tell. Okay, polymyositis, somebody said, is it inflammatory? Other treatable condition we think is inflammatory muscle disease. Somebody said inflammatory muscle disease. Is it a picture of inflammatory muscle disease or dermatomyositis?
Usually common in females, sir.
No, okay, male, female.
No
Okay, common in
history of-
females, it can occur in males also.
Not
it's not.
painful, sir, in this case.
But here what is there, which is usually not seen in inflammatory muscle disease? Drooping is seen. Huh? Drooping of eyelids presentation is there in any inflammatory muscle disease.
No, sir, usually muscle pain is present.
So usually it will be proximal muscle weakness, both upper lower limbs. Neck muscle weakness is more characteristic in inflammatory muscle disease. or sometimes they can have systemic thing. So it's less likely actually inflammatory muscle disease, because drooping is not ocular muscle involvement is not described actually much. Hmm. I just asked one question. Anybody? What is the commonest muscular dystrophy in adults? Which has drooping. There is many famous film personality also is there. So did you ask any history of any hand grip relaxation, any problem? Grip, relaxation of grip.
No, sir.
Like other words, did you ask for any history of myotonia?
No, sir.
So that is also important in this. Somebody comes to you with symmetrical proximal weakness, so myotonic dystrophy. In muscle, because there is no diplopia or anything, and in adults the commonest muscular dystrophy is, in children it is Duchenne's or XP21 myopathy, whereas in adults it's myotonic dystrophy. It's entrance bit adi. Commonest muscular dystrophy in adults is myotonic dystrophy. Can it be myotonic dystrophy?
I can.
Okay, because symmetrical and sometimes, as you showed here, Aadhaar card is showing a drooping of like eyelids 5 years back also.
Yes.
So many times they, because they think it is congenital or genetic, sometimes there may be subtle and progressive drooping of eyelids, and symmetrical proximal weakness is, we should consider. One is myotonic dystrophy. You should ask for history of myotonia. Hmm? So, okay, that is actually, if drooping of eyelids there, the other second common after myasthenia will be myotonic dystrophy. Any other muscle disease?
Chronic progressive external ophthalmoplegia.
Idi?
Chronic progressive external ophthalmoplegia.
CPUO, okay. But there is no double vision or any squint. So, but what disorder you are thinking? CPO ante enti? It comes into which disorder?
CPO is what type? Like what disorder?
For example, young female patient had a heart block also. That also can have ophthalmoplegia with proximal muscle weakness.
Especially when you say there is no diploma. So
Because no diplopia, so again you should think of that, those conditions, like any mitochondrial disorder. I don't know. Which mitochondrial disorder can present you with ophthalmoplegia with proximal muscle weakness? There also it will be symmetrical, not much of, but only thing is no family history, is not a product of consanguineous marriage. That also again more common in females and slightly delayed. You heard about Keene-Sarry syndrome?
Yes.
Second year or third year, Amma?
Second year.
Second year, okay. So that is one form of, we have tried there, ophthalmoplegia, attacks, ophthalmoplegia, this and complete heart block. So that is also one possibility, but is very uncommon and more common in females. And here it's 6th decade. So that is, okay, broadly we can say mitochondrial disorder. Any other thing?
by the time of your examination, if you feel that the eye movements, ocular movements are also restricted, you can go back into the history, put that up also. So you know a bit more than what we know right now. So you will be presenting a picture to me.
So because
Acquired causes like myasthenia or
as madam said, if ophthalmoplegia is symmetrical, many times patients will not bring out history of double vision. But only thing you can get some other history. What history you will have? Somebody has symmetrical involvement of both sides. Patient attendants may notice that he is moving his head when usually we move our eyes side to side or up or down for any communication. They'll say every time he's moving his head, right or left or up, whenever he's speaking, and eyeballs are not moving. Mm. So that history you didn't get. Mm.
Acquired causes like myasthenia and all, these are acquired causes. They start subacute to acutely kind. So more often asymmetry will be there. More often because of asymmetry, there is loss of conjugate gaze fixation. That's why they won't get, like they will complain more of diplopia. Your CPO or other inherited kind of cases, they will go on developing insidiously over years or so. By that time, there is almost kind of conjugate fixation and activation also, like these pathways get activated. That's the reason why more often they don't complain also of diplopia. It will be developing very insidiously. So in your examination, if you have any restrictions or so, en bloc head turning or anything, or can complain. Nothing of that sort. Extraocular movements are completely spared. It is only ptosis and subtle proximal weakness, at least that too progressive, without any set fluctuations or so. So still by the end of your history, at least muscle likely or CPO and your neuromuscular junctions. In neuromuscular also, if may not be a typical myasthenic kind of, myasthenia gravis kind of a syndrome, at least LEMS also can have ocular involvement, subtle ocular movements, involvement, very gradually progressive also. He's elderly, 60, 64 at least, late onset myasthenia versus something like LEMS should be kept into possibilities. Because again, as sir said, this is treatable conditions at least. Before telling CPO or anything kind of degenerative causes, come down to at least, sir, treatable conditions.
Okay, you can, just for broadly for everybody, you can discuss other, can it be a peripheral nerve problem? You know any peripheral nerve disorders where ophthalmoplegia and probably some proximal or distal, we didn't examine still.
I don't know, sir.
Why, like, how do you classify peripheral nerve disorder? That name itself suggests peripheral. So every neurological syndrome will come with a pattern. So when we ask about peripheral nerve disorders or so, any length dependent progression is there or not? Gradual onset, length dependent, glove and stocking kind of distribution, sensory symptoms are there or not? Peripheral nerves are mixed nerves. So any sensory, like these are all points which will decide you to take it against at least. You thought of muscle and NMJ, but you excluded peripheral nerve. We excluded peripheral nerve because
Sensory symptoms
exactly.
are not present and
Pattern.
only proximal involvement.
And
Perfect.
such ophthalmoplegia is very unusual, except maybe, can you get something like ophthalmoplegia in any peripheral nerve disorder? Acute, somewhat acute, more common in acute. ఎప్పుడు చూస్తుంటారు కదమ్మా Miller-Fisher syndrome. So Miller-Fisher variant of GB syndrome, you can get ophthalmoplegia. Otherwise, again, ocular involvement is unusual, but rarely you can see. Anything else? See, because just we can't from history. Can it be a brainstem disorder? Because you don't have any. One is okay. You don't have any other long tracts history from history. No sensory bladder or anything, but still it can be a brainstem.
Sir, third cranial nerve nucleus, single nucleus supplies both LPS. So ptosis can be present, but again diplopia commonly.
No, because okay, you came to a nuclear involvement. See, sometimes if it is a very small lesion, levator palpebrae has only a single central nucleus, so you can have bilateral symmetrical ptosis, and other nuclei may not have been involved. We don't know. But it is unusual, but still you have to keep in mind suddenly something turns up to and I have seen few patients, I thought myasthenia and some people have treated. There is a small cysticercosis in the midbrain. So there is a double vision and all that, but because the oculomotor nucleus, we have a different nuclei. So they can sometimes, if there is a nuclear involvement, you can get something like myasthenic weakness, asymmetrical, because some nuclear involved, some nuclear spared. So one of the conditions for myasthenia ophthalmoplegia, asymmetrical, is a midbrain small lesion involving the nuclei, oculomotor nuclei. Small, we have seen some cases. So still you should think in, but it comes less likely. Okay. So from history, whatever I could get. One is myasthenia, two common in elderly is a myotonic dystrophy with ptosis with proximal weakness. Other things will be, and from the examination we see. Okay, continue.
General examination, patient is conscious, coherent oriented, moderately built and nourished. No pallor, icterus, cyanosis, clubbing, generalized lymphadenopathy and pedal edema. No peripheral nerve thickening, no neurocutaneous markers. Vitals, blood pulse rate is 80 per minute, regular in rhythm, normal in volume and character, no radio-radial or radio-femoral delay, no vessel wall thickening, and all peripheral pulses are felt. Blood pressure is 120 by 70 millimeter mercury in right upper limb in supine position, 120 by 70 millimeter mercury in right upper limb in standing position. Respiratory rate is 16 per minute, abdominal thoracic type. Temperature is 98.4 Fahrenheit. Saturation is 98% at room air. Higher motor functions, right-handed individual, conscious, oriented to time, place and person. Speech is normal. Immediate, recent and remote memory is intact. Cranial nerve examination, perception of sense of smell is normal in both right and left side. Visual.
We thought of myotonic dystrophy.
Sir.
So, do you have any facial picture?
Sir, I have a video.
Huh?
Any typical
video.
faces for him clinically? Like, do you feel?
Face, just show the face. Okay. Face, I am not. Okay. What type of faces you get in myotonic dystrophy?
Temporal hollowing.
Okay. You will have something hatchet face.
Hatchet.
Okay. Mm.
Frontal balding, temporal hollowing.
Okay.
Cranial nerve examination, sense of smell is normal on right and left nostrils. Visual field, counting fingers on visual acuity, counting finger from 1 meter in right eye, 6 by 18 in left eye. Field of vision is normal, color vision normal. Fundus examination is normal in left eye, right eye could not be done, sir. Immature senile cataract is present in the right eye. External ocular movements are pain-free and normal in all directions.
Okay, cataract is there. Does it give you any clue? So, okay, he is anyhow elderly, so you can get cataract. But in some of these conditions we discussed, if cataracts are there, what does it, again, does it throw any light?
60 also. Presence of cataract points towards which of your differential conditions?
Well, maybe for her, I think.
Others can help.
Okay, myotonic dystrophy will have early cataracts. Huh? Okay. Is he diabetic?
No, sir.
No, it's okay.
Pupil size is 2 millimeters in right and left eye. Direct and indirect reflexes present in both eyes. Ptosis is present. Interpalpebral distance is 4 millimeters in both the right and left eye, sir. Upper lid excrusion test, 4 millimeter distance is there, sir, which indicates poor levator palpebral superioris function. No nystagmus, no meiosis, anhidrosis or inophthalmosis. Patient
No, you didn't mention extraocular movements. Before you go to pupils, extraocular movements.
I have mentioned. Pain-free and normal in all directions.
Extraocular movements are normal.
Normal.
Okay.
Able to patient perception of sensation over face is normal.
No, before you go to other things, if somebody has ptosis and your suspicion is myasthenic weakness,
few special tests.
what tests you will do?
Sleep test, fatigue test, cut and sign we see, sir.
Okay.
Kogan's slit twitch sign.
One is curtain, but he already has significant drooping. I don't know how much it will be useful. What other tests will do?
Ice pack test.
Ice pack, did you do ice pack test?
Yes, sir. No improvement.
No improvement, okay. Because it is a very highly sensitive test, ice pack. So no improvement.
No, sir.
And extraocular movements are completely full.
Yes, sir.
Mm.
Hydrophonium test.
No,
Other
that is
tests.
in later. But in examination, bedside examination, when you suspect myasthenic weakness, you should do tests for on exercise and improvement with rest. Like, as you said, cut and test, other eye closure, complete eye closure, and any improvement, deterioration, and improvement with ice pack.
Yes, sir.
Okay.
So that this was only upper lid ptosis.
Yes,
right?
ma'am.
So, like, how do you distinguish ptosis for like isolated ptosis and Horner's ptosis? You mentioned certain muscles also initially.
Sympathetic innervation, Muller's muscle is affected, ma'am.
Muller's is all around.
As in
LPS
both
is
upper
only in the upper.
eyelid and lower eyelid.
Perfect.
So you normally lower eyelid should be touching the limbus. If it is beyond moving up upper high, then lower eyelid is also involved.
In his case, it was only pure LPS scantosis.
Yes, ma'am. Can you continue? Jaw jerk is present. Patient is able, forehead wrinkling is present, sir. Patient is able to close his eyes tightly, blow air into the cheeks.
Okay. And what does it suggest? Like forehead wrinkling is present. If somebody has ptosis, what does it suggest?
Frontalis muscle overactivity, sir.
So, what happens in myasthenic weakness?
Because
So, like ptosis of third nerve and ptosis of neuromuscular junction. What is the difference? Both the eye closure and eye opening are weak, will be weak in myasthenia. And even frontalis also will be weak. So, if somebody has significant wrinkles, it indicates the frontalis is overacting, which is actually, unless there is a differential involvement of ocular and frontal muscle, usually in myasthenia, you don't get that significant wrinkles. Sometimes you may get it after rest, it may be there, but usually both eye closure, eye opening and frontalis overaction may not be there.
Okay,
So here it is overacting actually. When in facial nerve testing, how is the frontalis muscle action?
it's normal, sir.
Normal, okay.
Can
Eye closure is also normal?
Yes, sir, able to close his eyes tightly.
Tightly, normal. So that is also again slightly odd for a myasthenia.
Okay, sir. Able to blow air into the cheeks, sir. Taste sensation is normal, sir. Eighth cranial nerve. Rene's test, air conduction more than bone conduction in both ears, sir. Weber's, no lateralization is present. Uvula is central and both palatal arches are symmetrical, sir. Patient is able to shrug his shoulders and move head side to side. No winging of scapula is present. On protrusion of tongue, there is no deviation of tongue or no wasting of tongue, no fasciculation, sir. Coming to motor system, bulk, upper limb arm 34 centimeters on right and 34 centimeters on left. Forearm 24 centimeters on right side, 23 on left side, sir. Lower limb thigh 38 centimeters on right side and left side, and leg is 32 centimeters on left and right, sir.
But obviously any wasting is there on exam. Sometimes wasting may be symmetrical, so your measurements may be equal on both sides.
No, sir, patient, no wasting was seen, sir.
Okay.
Tone is normal in both upper limbs and lower limbs, sir. Power, shoulder flexion, extension, abduction and adduction.
For shoulder in this situation, you have to
Neck,
look for
sir.
neck flexion extension.
Sorry, sir.
Huh?
Neck flexion extension, normal,
Normal,
sir, 5 by
okay.
5, sir. Shoulder flexion, extension, abduction, adduction, 5 by 5 on both sides, sir. Elbow flexion, extension, 5 by 5. Wrist also flexion, extension, abduction and adduction, 5 by 5. Hand grip, 100% on both sides, sir. Hip flexion 5 by 5 on both sides, sir. Hip extensor is 3 by 5 on right and 3 by 5 on left, sir. Knee flexion is also 3 by 5 in both right and left limbs, sir. Knee extension 5 by 5, sir. Ankle dorsiflexion and plantar flexion is 5 by 5, sir.
So somewhat symmetrical proximal weakness.
Yes, sir.
Lower limbs.
Yes, sir. Superficial reflexes, corneal
For
conjunctiva.
reflexes, if you suspected myasthenic weakness, any tests you will do for getting motor weakness on fatigue.
Dynamic power. Dynamic power testings.
So you can do sit-ups. How many sit-ups you could do? Any arm abduction time, arm swings.
120 seconds.
Any increase in weakness? Okay. You did not have any weakness after exercise.
Early morning after waking up also no improvement in ptosis.
Okay.
Superficial reflexes, corneal conjunctival reflex present, sir. Abdominals present. Plantars flexor on both sides, sir, right and left. Deep tendon reflexes, jaw jerk, biceps, triceps, brachioradialis, knee and ankle 2+, sir, on both limbs. Sensory system examination, touch pain, temperature, vibration, joint position, sense and pressure, normal, sir. Cortical sensations, tactile localization, 2-point discrimination, stereognosis, graphesthesia, normal, sir. Cerebellum examination, no titubation, no nystagmus, no tremors, no past pointing on finger or finger nose test, sir. No normal dystiodocokinesia. Knee heel test is normal, sir. No gait is waddling type of gait is present, sir. Other system examination, CVS, S1 has to heard in all areas, normal S2 split is seen, no added murmurs, no added sounds or murmurs. Respiratory system, chest movements equal on both sides, normal vesicular breath sounds. Per abdominal examination, soft non-tender abdomen and no palpable organomegaly.
So we suspected something, I told you, myotonic dystrophy.
Yes, sir.
What will you look for if somebody is suspecting myotonic dystrophy? Because our elderly male, as I told you, symmetrical, no myasthenic type of weakness. One other common possibility is myotonic dystrophy. So what test you will do, or what you will look for? In the name it's there, myotonia. How will you look for myotonia?
Hand grip.
Hand grip, so delayed relaxation. Did you look for it?
No, sir.
Okay, that is one. Any other thing you will do? You can do. Sometimes you look for percussion myotonia. So you have to look for these two, myotonia and percussion myotonia. Okay. Continue. Finish your examination. So after examination also you didn't have any additional clues. So you're same, bilateral ptosis with lower limb proximal weakness. So your differential diagnosis will also be the same. So in neurology, most of the times history only gives you a lot of information. So and it will tailor your. So if you do an MRI head, many times these days youngsters are doing scans from above or below. The scan will be normal. So your history and examination are very essential in neurology for tailor-making your investigations. Otherwise, so history and examinations, clinical is still there today also. Even after AI also it will be there. So, okay. So what investigations you will do? Because the differential diagnosis, one is treatable myasthenia gravis, 2 myotonic dystrophy, maybe rarely 3 is mitochondrial disorder, because other things are very, very uncommon if you think of. So your investigations also be in this. So what investigation you will do?
We'll do hydrophonium tests, neostigmine tests.
Okay, hydrophonium actually is not available. Where do you do hydrophonium? Where do you do neostigmine? You must have read it. I just maybe it's more for you. Usually in heterophonium we do mostly in ICU to differentiate between myasthenic crisis and cholinergic crisis. Because when you examine, heterophonium is very short acting. So you can't examine the patient. Okay, only thing is if the patient had only ophthalmoplegia, if you give heterophonium, eye opening will be there. But usually we do in ICU setting to differentiate cholinergic crisis versus myasthenic. But we do a neostigmine test. Did you do neostigmine test for this
Yes,
patient?
sir, done, sir.
Any change?
No, sir, no
No
improvements.
change. So you all your residents should know how to do a neostigmine test. What precaution? He's 60 years. What precaution you will take?
We have to see cardiac functions. Sir.
Okay, one cardiac. Why?
Erythemias and
And you always give neostigmine. With neostigmine, you give atropine also for muscarinic this thing. And you should be careful when you are doing for elderly people. So there is no change. Okay, what other will you will do?
serum creatinine kinase.
Okay, serum total creatinine phosphokinase. Sometimes we write total also, many times we get MB. So you specifically have to write serum total creatinine kinase, CPK. What is it? Here?
Normal.
Normal, okay. Next, what will do?
Serum pyruvate and
No. For we may do so many things like hemogram, biochemistry, routine. We'll do a chest X-ray for any. What you will look for in chest X-ray? In myasthenia, what will you look for?
thymus.
Thymus, any mediastinal mass or anything, chest X-ray. Still you can do because many times your neostigmine test may be normal. Where neostigmine test will not be present in myasthenia.
Congenital.
No, not congenital. One is burnt out disease, late burnt out disease, or sometimes it may not. So, what other tests you will do? We must have done, Kada.
Repetitive nerve stimulation.
Decremental response, RNS, repetitive nerve stimulation. It was done.
Yes, sir, done, sir. Normal study.
Do you have graphs here?
Sir,
Okay.
I don't have the photo.
It's normal. So you have done post exercise also? Priya you must have done. Decremental both at rest and post exercise is normal. Okay.
Routine NCS also normal, amplitude center. NCS is normal.
All are normal, what will you do? If it is a myotonia, what will you do?
Muscle biopsy.
Muscle ki normal what test you will do for muscle? EMG. What you will see in EMG? In Chesa, did you do that? Okay. See, you look for myotonic discharges. We get what is called a typical dive bomber throttling of a motorcycle like sound. That's very characteristic for myotonic dystrophy. What other things you'll do? Did you do echo?
Yes, sir.
Normal?
Yes.
With myotonic dystrophy, many times patient can have cardiac disorder. Or even in myasthenia also you should look for. Then what did you do? So what is your possibilities? We thought now one is myasthenia. So did you give a trial for with any drugs?
Yes, sir, trial.
No response. So it's myasthenia will be less likely, but you can do what you have done antibodies.
Sir, due to
Patient not affordable. Okay. So what do you want to look for in antibodies, especially when all is negative?
anti-musk.
One is anti-acetylcholinesterase antibodies. Another is musk myasthenia. Sometimes musk myasthenia may not give all these characteristic features. Madam is also talking about LEMS, Eaton-Lambert syndrome. Eaton-Lambert syndrome, sometimes you can have actually ophthalmoplegia, rarely. But Eaton Lambert's, again, total CPK is normal. And
Reflexes were also normal.
Sorry.
Reflexes were normal.
so,
Myasthenia or LEMS, NMJ, by now should have had at least other stigmata in your examination, your electrophysiology at least. About CPO, at least pure ptosis more than by 60, 64 years age, and completely sparing extraocular movements, and little odd for even mitochondrials for him. Serum lactate levels, pyruate kinase or serum lactates, ammonia levels, they may point towards, but need not always be elevated also. For subtle, CPO is very restricted kind, unless it is CPO plus with proximal lower limb weakness or so. That time it might be.
you said patient is sick now. What happened? His face is not like myotonic dystrophy. Okay. But still, myotonic dystrophy is one of the commonest muscular dystrophy in adults. So you can, what test you will do for confirming myotonia? Because sometimes in myotonic dystrophy, sometimes myotonia may be significant, may not be sometimes clinically significant. నేను తర్వాత మళ్ళీ ఫోన్ చేస్తాను, బిజీగా ఉన్నాను. What tests you will do? So genetics. So even for mitochondrial or even for myotonic dystrophy, you can do clinical exome sequencing because it's one of the very common muscular dystrophies in adults. And it's many times it may not be having all the typical features. Sometimes some patients can present to you with to a cardiologist. Sometimes they may present to a ophthalmologist because the other weakness and all that may not be very prominent for everybody. Patient can have diabetes or infertility. So it has a lot of systemic this thing. So, okay. Anything more you want to add?
With increased weakness also, still there are no progressive signs. Like prior to that time, at least he is ambulatory completely. Now he's bedbound.
When he was admitted here, he was ambulatory. I will show you the gate video,
Yeah.
ma'am.
Now, like
Now,
how much interval? Like how long it became
now I have not enrolled
with febrile illness.
This was around 10 days back, ma'am, when he was admitted.
No, for fever precipitating weakness, again, might go in favor for mitochondrial possibilities at least. But if at all progressive weakness is there, lower limb weakness, power has gone down, and still your reflexes and everything is well preserved. Possibility of other neurological, peripheral GB or MFS symptoms and all that at least goes down. So,
Nerve conductions are normal?
Yes, sir.
Okay. Still, one is myasthenia, this thing will myotonic dystrophy because it's more common. Then other could be a mitochondrial disorder. But mitochondrial again, 6th decade presentation is slightly unusual. They usually present in maybe 2nd decade, 3rd decade or drugs. Pyridostigmine also, it was given no improvement with pyridostigmine.
Yes, sir.
The only thing is you look for myotonia on EMG, just you can put a needle and see.
Yeah, yes, sir. I will do.
Given CPK norm could be normal and look for any clinical evidence of myotonia.
So bedside you just
Percuss and see. Because sometimes any of these conditions.
Myotonia is not there, sir. Not there, sir.
so it is not fitting into
Could be still mitochondrial. Myotonia, always myotonia may not be there, clinical myotonia, but you can look for EMG evidence for myotonia. And otherwise, maybe if patient is affordable, you can do a genetic assessment. Okay.
Thank you, sir.
Thank you, Dr. Shravani, for the excellent case presentation and our esteemed speakers for sharing your valuable insights and thoughts. It was truly an engaging and enriching session.
We extremely, on behalf of our Department of Medicine, GEMS, we're extremely thankful to our guest speakers, Dr. Buchiraju, Dr. Anuja Patil, who have enlightened our students and inspired them to what to learn. So thank you so much. Would like to see similar interactions, interactive classes in future also. Thank you so much, sir.
I request the dignitaries on the stage to kindly take their seats in the audience. It is an honor to invite Dr. Buchiraju sir, former principal and head of the Department of Neurology, Andhra Medical College, for the next session. We are also privileged to have Dr. Anand Shastri sir and Dr. Kranti ma'am to chair the session. I request you all to join us on the stage.
Good afternoon, everyone. It gives me immense pleasure and privilege to introduce today's distinguished speaker, a towering figure in the field of neurology, Professor Dr. G. Bucci Raju, MD, DM, FIAN, FAN, a clinician, teacher, researcher, and leader par excellence. Dr. Raju's contributions span nearly 4 decades. He began his academic journey with MBBS and MD from Andhra Medical College, Visakhapatnam, and went on to earn his DM Neurology in the prestigious AIMS, New Delhi in 1992. His academic brilliance and service have been recognized internationally and nationally, being conferred with Fellow of the American Academy of Neurology FAN in 2021 and Fellow of Indian Academy of Neurology in 23. We are truly privileged to have him with us today, and I warmly welcome Professor Dr. G. Bucci Raju to address the CME topic. Thank you.
Good afternoon, everybody. I once again thank Department of Medicine, GEMS, Dr. Sudhir, Dr. Priya, Dr. Anand Sastri for inviting me for today's CME. Kranti and Priya are my students in DM. So it's a privilege for me to address to you. Actually, I was asked to speak on CNS demyelinating disorders. When we think of CNS demyelinating disorders, commonly olden days we used to think of mostly multiple sclerosis. But in India or in Asian population, multiple sclerosis is quite uncommon when compared to the West and Europe. As you go away from the equator, multiple sclerosis is quite common. Last 2 decades has seen a lot of advances in CNS demyelinating disorders. You must have heard in peripheral nerve demyelinating disorders, you have GV syndrome, CIDP and all that. In central nervous system, last 2 decades have seen a lot of change. The other 2 common disorders, which are actually, one is described 2 decades ago, the other one is just a decade ago. This is a neuromyelitis optica spectrum disorder and MOG, or myelin oligodendrocytic protein associate disorder, which was described just a decade ago. So these 2 are quite new disorders, maybe for youngsters. And the important is you have to identify them, and if you treat properly and aggressively, you may have a better outcome. And you have to differentiate this from other CNS demyelinating disorders like multiple sclerosis or other secondary demyelinating disorders which occur in the central nervous system. Many of you must have heard about Devick's disease, which is presence with blindness with spinal cord involvement. Way back in, actually it was described more than a century ago in 1894 by Devick. Then people thought it could be a form of opticospinal multiple sclerosis. For a long time, many people thought Asian form of multiple sclerosis. But we know after 2007, after the description of aquaporin 4 antibodies, we know most of these are actually NMO spectrum disorders. So NMO spectrum disorder story started from Mayo Clinic when the antibodies were detected in some of these conditions where they thought multiple sclerosis in 2005-6 during that time. So NMO spectrum disorders have actually evolved in only last 2 decades. Whereas coming to myelin oligodendrocytic MOGAD is actually described in only last 10 years. So relatively new disorders, but there are a lot of advances, and most of them are more seen in non-Caucasian population, like in Asia and other, it is seen throughout the world, but it's more commonly seen in non-Caucasian, non-white population. So it's more common for us. Last 6 months I've seen around 6 cases of NMO or MOGAD, but I haven't seen any single new case of multiple sclerosis. So these are more common than actually MS, which we all talk in our both MD and DM level. So again, other important is these disorders are quite, they produce significant disability in quite a young population, because most of these present in 3rd and 4th decade, like any other demyelinating, CNS demyelinating disorder. So it's very important for us to identify them and treat at the earliest. So coming to the diagnostic criteria for NMOSD, or neuromyelitis optica spectrum disorder, as I told you, even though it was found out clinically a century ago, as I mentioned, Wingerchuk actually first described, they gave the initial criteria in 2005, but we had the actual international panel against neural IPID criteria, which came up quite recently in 2015. So it's quite a new, just a decade old disorder. So I just present this case which we actually presented, this child we presented as a Wernicke's encephalopathy in a child. Once the patient presented to us like with intractable vomitings and hiccups, at an MRI showing a periventricular white matter or hyperintensity, and the radiologist said it's Wernicke's encephalopathy. And we thought patient also had some nutritional skin changes and all that. We thought, and patient improved spontaneously with treatment. So initially we thought it is Wernicke's encephalopathy. On follow-up, this we described more than 12 years ago and even presented in the national conference. But this child turned out to be NMO spectrum disorder, and the presentation is area postrema syndrome. So somebody who comes to you to casualty, like a Wernicke's encephalopathy, you should still suspect NMO spectrum disorder. This is also quite common, and this child had a transverse myelitis later on after 3-4 years on presentation, and our aquaporin 4 is positive. Similar comparative Wernicke's encephalopathy-like presentation has been described in literature. This was described in Journal of Neurology in just last year. So coming to the immunopathogenesis of all these disorders, all are quite different, whether it is a multiple sclerosis or NMO spectrum disorder or MOGAD. The disorders, even though they appear, clinical appearance may be slightly similar, but the immunopathogenesis and the biomarkers are quite different. Coming to NMOSD, NMOSD is due to aquaporin 4. Aquaporin 4 receptors are seen in the astrocytes. Astrocytes form the backbone, a structural bone for the CNS, this thing. And whenever there is some insult, whether it would be infective or non-infective insult, aquaporin 4 antibodies are formed, and they And there is some disruption of blood-brain barrier in some areas, causing destruction and demyelination. And they, as usual in any demyelination or inflammatory disorder, there is activation of both B cell, T cell reactivity, and also complement pathway and inflammatory IL-6 and all that cytokines, and it causes some specific syndromes, mostly where there is like periependymal, like in, as I already mentioned, in the spinal cord, in the optic nerve, or in the periventricular, in the brainstem, area postrema or diencephalon. So that's why you see the clinical syndromes in the same situations. Similarly, in MOGAD, MOGAD is a myelin the oligodendrocytic protein, which is there in the cell surface of oligodendrocytes. So if there is any autoimmune similar to NMOSD or any other autoimmune disorder, if there like MOG antibodies, IgG antibodies are due to some reaction are produced, again it causes inflammation and demyelination of these cells. And again, both MOGAD and NMO has a similar type of clinical presentation, but both in terms of natural history and also in prognosis, they are quite different. So coming to the diagnosis of these disorders, how do we diagnose? As I already mentioned about, this is for NMO spectrum disorder, they have 6 core clinical presentation. One is bilateral optic neuritis, the other is longitudinal extent transverse myelitis, what we call LETM. 3 is area postrema syndrome. 4 is diencephalon syndrome, where the patient presents with insomnia and narcolepsy or sleep disorder. 5 is any brainstem syndrome or any cortical syndrome. So these 6 are classical clinical, so core clinical findings. So you should have one of the core clinical with positive aquaporin 4 antibodies and MRI typical of NMOSD. Then we describe this patient is suffering from NMOSD or neuromyelitis optica spectrum disorders. But in quite a significant, like 1/3 of the patients, maybe some of these could be MOGAD or other autoimmune disorders, 1/3 to 1/4 there can be aquaporin 4 negative. So in aquaporin 4 we should have two core clinical features, out of which one should be whether optic neuritis or transverse myelitis or area postrema syndrome. So if it is aquaporin 4 negative, you need to have 2 core clinical features with typical MRI features. If it is positive, 1 core clinical, you can diagnose NMOSD. Unlike in, we don't have any proper biomarker for MS, but we have a proper biomarker for NMOSD. Aquaporin 4 antibody is quite positive. And it is being done routinely, even in Visakhapatnam nowadays is being done. So there are 2 core, as I mentioned, a common is optic nerve involvement, bilateral or longitudinal extent transverse myelitis. I will be going to this in MRI again. The other feature in multiple sclerosis, you have visual loss, which is usually unilateral and partial. Sometimes it could be even severe visual loss, but it's usually unilateral. Whereas in NMO spectrum disorder or in MOGAD, there, if somebody presents with acute visual loss in both eyes without any other features, we should suspect either of these two. So how does this present? Like NMOSD present, as I already told, acute visual loss which progresses for few days. They sometimes can be painless, or sometimes they could be local periorbital pain, some pain and movement. So that is one presentation. 2 is the longitudinal extent transverse myelitis, quite what we call transverse myelitis like presentation. Many times we have seen in, previously we just treated with steroids, but now we know most of these are usually in multiple sclerosis, the myelitis usually is a small white small plaque, so asymmetrical weakness or not complete myelopathy. Whereas here, both gray, white matter is involved, gross, dense myelopathy with paraparesis, both bowel and bladder involvement, mostly in cervical dorsal or even lower dorsal. So myelitis, longitudinal extent, transverse myelitis, and MRI, you should have 3 segment involvement. More than 3 segment involved. Usually in multiple sclerosis, you have 1 or 2 segments and not complete spinal cord involvement. Usually it's in the white matter, partial involvement. The other is area postrema syndrome. Area postrema syndrome, as I mentioned, area postrema is for patient presents to you with vomitings or hiccups and some midbrain like ophthalmoplegia. Last time we were discussing just now, ophthalmoplegia with some ataxia. So typical like a Wernicke's encephalopathy, area postrema syndrome. So in a female, something like Wernicke's, you should suspect if there is a periventricular white matter in the midbrain, you should suspect NMOSD. The other is diencephalon syndrome. Patient presented with narcolepsy, sleep disorder, and other features. Sometimes it can have a brainstem involvement or cerebral cortical involvement. So these are the typical features for NMOSD. So how do we diagnose? We have some biomarkers I already mentioned. So the typical biomarker is aquaporin 4 IgG antibody. Only thing is culture-based assay is more specific when compared to other ELISA or some other assays. We can do other markers also, and we can do to exclude multiple sclerosis, oligoclonal bands in CSF. And we have a typical MRI features which I will be discussing. So this is one of the recent studies which showed other biomarkers in NMOSD. NMOSD can be, here in this graph we see glial fibril GFL, glial fibril acid in CSF and quantitative albumin are quite significantly increased during a relapse in NMOSD when compared to other MOG or aquaporin negative or even in multiple sclerosis. Then coming to the other disorder, other CNS, which is actually quite recently described, 10 years, just recent 10 years, and which was also quite commonly present in Asian non-Caucasian population as equal incidence as NMOSD is myelin oligodendrocytic glycoprotein MOG associated disorder. Here also, as you see here, the classical presentation in adults is bilateral optic nerve involvement. Again, transverse myelitis, longitudinal extended transverse myelitis. But unlike in NMOSD, these patients doesn't have that area postrema or diencephalon syndrome, but they can have brainstem syndrome or cortical syndrome. But other feature is a typical encephalitic type of picture, like it can present to you like autoimmune encephalitis. And in children, the classical presentation, as you see the third where ADM-like presentation. So you know now acute disseminated encephalomyelitis-like presentation, where multiple demyelinating acute disseminated encephalomyelitis, which was described in children. Initially we thought it's we don't have any biomarker, but 50% of this, 50 to 60% of this ADM-like presentation in pediatric population are again MOG-associated disorders. So similar to NMOSD, for MOG also we have this criteria. We should have any of these, you should have all the three features, like one is clinical presentation, two is biomarker MOG IgG antibody on cultural assay, three is again a typical MRI feature. Here the clinical presentation, you should have either of these three, like acute or subacute optic neuritis, acute or subacute myelitis, ADM-like presentation, cerebral, which could be diffuse encephalitic or focal or multifocal involvement, or a cerebral cortical encephalopathy. So presentation can be one clinical, one biomarker like MOG positive, three is a typical MRI. The same thing, only thing is the presentation optic neuritis when, in both NMOSD and MOGAD is bilateral. Multiple sclerosis usually painless, could be painless, very unilateral, and here the blindness is more significant in compared to multiple sclerosis, bilateral involvement. So bilateral visual loss, some painful, without any other feature, you should suspect either aquaporin 4 or MOGAD. So anybody, you have to do both these antibody panel. So it's being done now routinely. The other is myelitis, myelopathy. Also presentation will be like a longitudinal extent or a transverse myelitis. But one other typical presentation in MOG is they present lower spinal cord, which is unusual in NMOSD. Is MOG presents to you with conus and cauda equina involvement. If they are, especially in children and young adults, if there is a conus or cauda equina involvement with white matter involvement, demyelination, you should suspect MOG disorder. And whereas area postrema like presentation or diencephalonic presentation is not routinely seen in MOG presentations. So spinal cord here it is lower spinal cord, whereas most it can be anywhere, but most commonly in dorsal, lower dorsal or conus or cauda equina, whereas in NMOSD it's in the cervicodorsal. So this is the MOG clinical presentation in different, both in adult and children. As I mentioned, ADM-like presentation is quite commonly seen in children, whereas MOG presentation and encephalitic type of pattern, whereas in adults it's mostly like bilateral optic neuritis and longitudinal extent transverse myelitis. And other thing is relapses are quite uncommon in MOG when compared to aquaporin 4. Aquaporin 4, like in multiple sclerosis, it can be a relapsing course. So relapses are quite common with NMOSD, whereas MOG, 50% doesn't have relapses. And both in NMOSD and MOG, oligochondral bands which you see in CSF in 90% of multiple sclerosis are not seen. Occasional, maybe in 10% you may sometimes see in MOG disorders. So this is a recent patient which I saw, an IT professional who actually from Vizag but working in Hyderabad, present to us with acute visual loss in both eyes, and it showed a papilla edema with papillite, periretinal perimacular hemorrhages. And this patient has MOG positive. And the MRI showing actually, even though patient is well preserved, doesn't have any other feature, MRI showing diffuse multiple levels area of white matter involvement. And this patient had MOG positive, aquaporin 4 negative. See, again, in aquaporin 4 antibodies, its optic nerve involvement is mostly posterior, like chiasmal or posterior. So sometimes the fundus may be normal in aqua, even though there is severe blindness or subtle changes. Whereas in MOG, it's mostly anterior, so papillitis or papilledema type of picture is seen in MOG. And this patient improved quite significantly with IV methylprednisolone and plasmapheresis. NMOSD doesn't respond so well when compared to MOG. So MOG patients do very well if you give, if somebody comes to acute visual loss and MOG positive, if you treat properly with methylprednisolone, maybe followed by, depending on response, followed by plasmapheresis. This patient had done very well, and visual acuity improved to nearly 6/12 in both eyes within 2 weeks. As I already mentioned, some of these patients may not show antibodies, but still the evolving subject, it may be other antibodies may be seen. So we should, aquaporin 4 negative, but typical clinical features, should we still treat like NMOSD. Just to highlight our experience at Andhra Medical College, when Kranti, Priya, all are working, we had presented this one of the state conferences, 21 decade presented 10 years study. We had nearly 65 patients, and 46 patients are diagnosed as per IPND criteria. The other differentiation between multiple sclerosis and all these two conditions is NMOSD is common in females. Normally is 9:1. So 1 male, 9 female. Whereas MOG is 3:1. So these are more common in females. Here also we had 75% are females. And age distribution, most of these, like NMOSD, mostly will be in the 3rd or 4th decade, but we have seen, as I showed you one case, aquaporin 4 positive pediatric age group also. Whereas in MOG disorders can be seen in any age group, but more younger. In pediatrics is more, as I mentioned, ADM is quite common in young. So this is our study showing the age group, mostly in the 30 to 50 age group. Another important feature, unlike in multiple sclerosis, is aquaporin 4 can be associated with other collagen vascular diseases. So some of our patients had associated SLE, systemic sclerosis, ichthyosis, and other conditions. Those patients do badly. Mortality is quite high. Initially, many people thought NMO spectrum disorder is only monophasic illness, but we now know that most of them are relapsing like in multiple sclerosis. So we presented this and it's published in Journal of Interior University of Health Sciences. And 40% of our patients, this is only a short follow-up of, even though we had these patients for 7-8 years, because Aquaporin 4 was started doing probably only in 2010-12 sometime from Visakhapatnam, because previously it's costly and many times our patients from KGH who are not affording. So 40% they had recurrence, and NMO positivity in all these recurrent cases are positive, 100% positive, and they had high mortality and associated with other illnesses is more common. So this chart shows the differentiation between NMOSD, Aquaporin, and MOGAD and multiple sclerosis. As I already mentioned, coming to the age group, in pediatric age group is more common in MOGAD, whereas quite young adults, mostly in females, it can be seen in all the three, but 9:1 female to male ratio is more common with NMO spectrum disorder. The other thing could be the relapses. Relapses are much more common with NMOSD and multiple sclerosis. In MOGAD, it's quite less. So only 40-50% had relapses. And the type of presenter I already mentioned, anterior visual pathway more involved in bilateral in MOGAD, posterior in NMOSD, and mostly unilateral partial involvement in multiple sclerosis. We have a different multiple sclerosis criteria. Maybe many of you, if you're interested, can read. We had the olden clinical Shoemaker's criteria, but now what we follow is the McDonald's criteria. Then the area presentation. The typical presentations in NMOSD are, as I mentioned, like bilateral optic neuritis, area postrema, transverse myelitis, or diencephalonic syndrome, whereas in MOGAD it's again bilateral optic neuritis and myelitis, and cauda equina or ADM-like presentation, which is very characteristic of MOGAD. So just coming to MRI to differentiate all the three, if you look here, the top one is the NMO spectrum disorder, where the optic nerve involvement, if you do thin slices for orbit and even with contrast, here will be the, again, longitudinal extent, posterior optic nerve, including the chiasma, like you see here, chiasma involvement here. See here, this is the chiasmal involvement and bilateral posterior optic nerve, as you see here. Whereas in MOG, it's mostly anterior, like you see here. And on contrast, we have what is called perineural contrast enhancement or perineural sheathing, like you see in bilateral. Whereas in multiple sclerosis, I already mentioned, usually it's unilateral and partial optic nerve involvement, like in this patient. Coming to the spinal cord involvement, I already mentioned in NMOSD, we have what is called a longitudinal extent, more than 3 segment involvement, mostly in the cervical and dorsal region, what we call LETM-like presentation. And on contrast, you have something like this peripheral contrast enhancement. Sometimes they have bright spots-like presentation. Whereas in MOG disorder, it's mostly gray matter and just peripheral white matter involvement, and it's what is called a H sign. H sign is seen with MOG associated disorder, and cauda equina involvement is quite commonly seen in MOG. Like this patient, this is H sign, and this otherwise sometimes both can have a similar type of spinal involvement. The third, in multiple sclerosis, predominantly like partial. Sometimes you can have multiple level involvement or only white matter involvement without gray matter involvement, partial spinal cord. So most of the times it could be a symmetrical presentation with bladder, without bladder, and the paraparesis may not be as power like 0 to 1 by 5 in either of these two in multiple sclerosis. So this is the spinal cord presentation in all the three. So we have a typical. So usually if somebody comes to you with Aquaporin or MOGAD, you have to do both brain and spine MRI to have a proper localization. So this is a presentation in brain. So as I already shown, like area postrema, midbrain, periventricular involvement in Aquaporin 4, or a diencephalonic involvement, or a corpus callosal involvement like or a basal ganglia sometimes in, but brain involvement is not so common in aquaporin 4, unlike in MOG. MOG, we have both bilateral middle cerebral MCP, middle cerebral peduncular involvement, or some cortical or even thalamic involvement like in Japanese encephaloid. So bilateral putaminal J-shaped J sign you may see here, or a encephalitic pattern. Whereas in multiple sclerosis, you all know the classical description of Dawson's fingers with periventricular white matter involvement parallel to the ventricles and or subcortical juxtacortical or U fiber involvement typical in MS. So even in brain involvement, pattern is different in all the three conditions. The same thing here, the H sign in Mogad, and longitudinal extent spinal cord involvement in aquaporin. And whereas in multiple sclerosis, partial, as you see here, only half, one side is symmetrical partial involvement of spinal cord, predominantly white matter. And again in brain, as you see here, it's more like in the chiasmal involvement, periventricular involvement. Whereas in sometimes ADM-like presentation in MOG disorders, whereas in MS, you have, as I already mentioned, periventricular plaques which are perpendicular to the ventricular and Dawson's fingers on sagittal images. I already mentioned about why you are very important for diagnosis and is to prevent, one is prevention of the acute attack and another is prevention of relapses. As you see here, in aquaporin, because of this acute insult, there will be significant deficit even after treating the first attack. And the recurrent episodes or relapses are quite common with aquaporin 4 and NMOSD. And I already mentioned only 40 to 50% have relapses in MOG and relapses. And the relapse, the acute attack responds very well with acute immunosuppressive treatment in MOG disorders. So that's why you have relapses, independent relapses sometimes. And only, especially in adults, in mostly in 30 to 40% of cases. Whereas in multiple sclerosis, you must have read what we call relapsing remitting MS, going on to secondary progressive MS or multiple sclerosis or a primary progressive MS. So diagnosing these demyelinating, central demyelinating, important for treating the acute attack, and maybe you have to exclude other conditions, secondary demyelination like in what you see sometimes in collagen vascular disease, sarcoidosis or infections. So if you have some presentation, but you should be very careful before we diagnose primary CNS demyelinating disorders, other conditions. So the red flags here are if the patient's symptoms has evolved only within few hours, like 3 to 4 hours, that is more of vascular-like presentation. So it's very unusual in demyelinating disorders. Usually in demyelination will be days to a month. If the progression is also a chronic progressive more than a month or 2 months, then you should suspect some neoplastic or other conditions. And active coexisting disorder that could mimic NMOSD. But still, as I mentioned, some of these patients can have associated collagen vascular disease, but sarcoidosis, other conditions you have to exclude, or even in our situation, tuberculosis, you have to exclude. And evidence of strong peripheral nerve involvement. Usually these are CNS demyelinating disorders, so you will not have any peripheral nerve involvement except in probably in Mogad where there is a cauda equina involvement has been described. And on MRI, if you do a contrast, if the contrast enhancement is seen after 3 months also, because these are all demyelination, usually the progression is there for few weeks, 4 weeks. So if there is active contrast enhancement even after 3 months, it's probably you should look for other conditions. And as these two have a typical biomarker, if the oligochondral bands are present in these two conditions, we should also look for MS, because oligochondral bands is a classical marker in multiple sclerosis. Then coming to the treatment of acute attack, whether it is NMOSD or MOG, acute attack, if once you diagnose, if you have a core clinical feature and antibody positive and MRI typical, so then you treat. The acute treatment is, one is IV methylprednisolone. In adults, what we give is 1 gram per day for 5 days. Some people give tapering doses for a month or 2 months, especially in Mogad or even in NMOSD, because whereas the response in multiple sclerosis is quite significant, and even in mock disorders with IV methylprednisolone, they do respond very well. If they doesn't respond as well with IV methylprednisolone, these patients do well with the plasmapheresis. So plasmapheresis and IV methylprednisolone, in most of the patients, they do well in both aquaporin 4 antibody positive NMOSD or in MOGAD. Whereas in multiple sclerosis, if that doesn't respond to methylprednisolone, we give IVIG. Here we mostly give this. IVIG has a limited role in these two CNS demyelinating disorders. So plasmapheresis, many studies have shown a significant response if they doesn't respond with IV methylprednisolone. So now plasmapheresis is easily done with our help of our nephrology colleagues. So and it's in India relatively cheaper when compared to even IVIG, because alternate day for 5 cycles, most of the times they do well. So previous days we used to use other immunosuppressants for prevention of relapses, especially in our situation in government setup like azathioprine, mycophenolate, and methotrexate we have used. But later on, we have used mostly rituximab, which attacks on the CD B cells. Rituximab is quite relatively less costly when compared to other newer modalities which I will be describing for Indian patients. Many people have done. In our study, people who are on rituximab, in that 65 cases, we are given for nearly later on, because initially the rituximab is not available. We are the disease evolution clinically, even internationally, is quite. Last few years, we have used rituximab in nearly more than 20 patients, except in 2. Most of the other patients, relapses could be prevented. So for prevention of relapse, we have different drugs now, which anti-CD20, that is rituximab, anti-CD19 is inebilizumab, anti-IL6 is satralizumab or tocilizumab, you must have heard during COVID, and anti-C5 is esulizumab and ravulizumab. All these drugs have been well studied. We have had double-blind trials, and most of these studies FDA has approved for aquaporin 4, NMOSD, all these drugs. But out of all these, probably in India we use only rituximab, which is available and much cost-effective in our setting. So the same thing, mechanism of action. Eculizumab, as I said, eculizumab and eculizumab acts in the, as I already said, in the anti-C5 complement at the C5 level. Complement. Whereas satralizumab is at the CD19, IL6, satralizumab at the IL6, anti-IL6, and so in the pathway of inflammatory pathway, both in the T cell, B cell, and complementary pathway and cytokine pathway, we have several antibodies. I think probably in many other immunological conditions, so many new antibodies are coming up. So rituximab is a first-line option which we are using in our setting. So the same thing, other new drugs which have been tried are IL-6 directed, approved like satralizumab, and B-cell derived cell therapies like inebilizumab, and complement-mediated cell like eculizumab. So all these are actually already approved by, most of these are approved by the FDA because of the double-blind trials. And these are the, how do you give the dosages and all that. If somebody is interested, can read. Previously, we used to use azathioprine, mycophenolate. Of late, with the introduction of rituximab, which is once in 6 months, it's easy to use, and we are mostly using rituximab. So these are the dosages for the different drugs. Somebody is interested can read, or if you have a patient, we can. But most of the other new drugs are quite costly. Even in US, they are in probably $500,000 or something per acute treatment. These are the new evolving drugs which, like you see in oncology, different monoclonal antibodies acting against JAK or other areas of inflammation. Several new drugs have been under trial. So for long-term management, initially we give first line, like IV methylprednisolone, plasmapheresis, followed by either of the rituximab, or in a government setting, people can't afford, we use azathioprine or mycophenolate. Otherwise, in areas where either of eculizumab, inebilizumab, or satralizumab also are approved as first-line treatment. So if they doesn't improve with one drug, rituximab, maybe we can add another new drug or azathioprine with this situation. So aquaporin 4 positive do well with these immune modulating agents, biological therapies. And for double negative, like both MOG and NMO, aquaporin 4 negative, usually the response is not so very good. IV methylprednisolone, plasmapheresis, again you give, mostly we are giving rituximab. But in internationally, satralizumab, which was tried in negative patients, is being approved. So this is just a recent, in JNNP, very recently published by a European group, like 25 NEMOS, what is called neuromyelitis optica group from Germany. They had a different, they also had a quite, this is the different, nearly in quite a good number of 320 patients with aquaporin 4 positive, 40, and MOG also 120. As you see here, age, as I already mentioned, is quite common in younger age. MOGAD is common in younger age. Age of diagnosis also is quite less. Whereas females are much more common in aquaporin 4 when compared to MOG. And the different types of presentation, like a typical presentation like optic neuritis, transverse myelitis can be seen in all the three groups. Whereas optic neuritis and like together, like opticospinal or DIVIX type of presentation more seen with aquaporin 4. But there's recently, actually, last week we had one patient from Orissa when I was in NRI Medical College. But that patient had bilateral blindness with transverse myelitis. And other brainstem like area postrema syndrome or Diamond-Kneflick syndrome are seen in aquaporin, which I already highlighted. And comorbid autoimmune disorders are quite commonly seen in aquaporin 4, not in MOG. And as I said, relapses are more common in aquaporin 4. So as you see here also, immunomodulating therapies, they do very well in aquaporin 4 positive or negative cases, but not in MOG, because I mentioned MOG doesn't have so many relapses. So you don't need to give any prophylactic therapy, especially maybe if somebody has a second episode, then only you should consider, especially in adults. And this chart shows the different drugs evolution in over years. As I already mentioned, initially everybody used azathioprine, mycophenolate, next rituximab, is green is rituximab. And now, as you see here, maybe in Europe, there other new drugs like eculizumab or inebilizumab and satralizumab have been used. Mostly they are probably in trials. So this is the algorithmic chart. If somebody presents you with a typical clinical picture of bilateral optic nerve involvement or transverse myelitis or any brainstem, you should do for aquaporin 4 panel. If aquaporin 4 positive, it becomes aquaporin 4 positive NMOSD. If it is MOG positive, it becomes MOG. And in children, you should look for ADM-like presentation. You should think of MOG disorder. If these are positive and your diagnosis is either of these, then you should treat with IV methylprednisolone with plasmapheresis. Most of the patients, they do well. For prevention, we mostly using rituximab in the classical dose, twice fortnightly or every week for first 4 weeks, then followed by after 6 months. If CD19 and 20 are normal, so we use rituximab to prevent prophylaxis. So if you treat and diagnose properly, most of these demyelinating CNS demyelinating disorders do well. So I once again thank the Department of Medicine from GEMS for asking me to speak on something new, actually. I think MOG and aquaporin, but we are seeing quite frequently nowadays. So we should be doing for most of these patients. Actually, this antibody testing is nowadays done in around 6,000-7,000. You can do a panel, both MOG and aquaporin, and we can easily treat some of these patients. I thank you again, one and all, for your patience.
It's a very excellent and vast talk, sir. Sir, I just remind you one case, sir. Actually, I discussed with you previously. The young middle-aged man presented with mild headache with minimal blurring of vision, sir. Initially, I thought of IIH because he had papilledema with no peripapillary hemorrhages. Because he's apprehensive, I admitted him. CSF opening pressure is also high, sir. But suddenly on third day, he had sudden visual loss, asymmetrical visual loss. Then I discussed with you. You suggested to order NMO and MOG antibodies. Surprisingly, he was MOG antibody positive, sir. So there is a variant in MOG which has optic disc edema and even high CSF opening pressures.
Yeah, yeah. Actually, I didn't, the case which I showed you, actually, she was working as an IT professional both in Hyderabad and Bangalore. Initially, she was diagnosed for more than a year as IH. I didn't tell all the past history. That patient presented with acute headache and papilledema, and she was diagnosed with IIH, and Diamox was given. Patient responded quite well and done very well. So she has initial MRIs. Initial MRIs were normal. So after later on, when the patient presented with bilateral visual loss, she went to some neurologists in Bangalore and ophthalmologists. They just thought it is IIH only, and they left the patient. They didn't do even a repeat MRI. Then the patient came to us. So the similar, actually she was diagnosed with IIH and papilledema, and she improved actually. But now she had typical papillitis like picture and MRI showing diffuse white matter disease. So probably in all IIH patients, especially if there is significant visual loss in and short history.
Yes.
Usually if you have a short history and acute visual loss and something like bilateral papilledema or papillitis, probably we have to do, because that line of treatment is entirely different, and you should, because suddenly if somebody young, male or female loses their vision by mistake, so better to do probably MOG or acoporin 4 antibody panel for all these patients who have somewhat significant visual loss in with papilledema, papillitis like picture in this thing. In MRI, what happens is many times we don't do a proper orbital cuts with thin slice MRI. So MRI sometimes may not show what has been described like chiasmal involvement. Sometimes we don't do, because of maybe financial reason, we don't do contrast in MRI, like chiasmal involvement or longitudinal extent or perineural sheathing. So sometimes we miss if you're not doing a proper thin slice MRI for orbits. So as you mentioned, probably you should be very cautious when you are treating patients with IIH.
Thank you, sir.
Thank you, sir, for enriching our CME with your expertise.
Session is open for questions.
Any questions? I request Dr. Anand sir and Dr. Kranti madam for felicitating Dr. Buchiraju sir.
Now I request our APMC observer, Dr. C. Sudhakar Garu, to come onto the stage. Dr. C. Sudhakar Garu completed his MBBS from Andhra Medical College and DPH from Rangaraya Medical College. He is currently serving as Executive Council member for Dr. NTR Health University, President of AP Medical Council, and as in charge MO for TDP Parliamentary Doctor Cell. I request Dr. K. Sudhir sir and Dr. Madhusudan Babu sir to felicitate Dr. C. Sudhakar Garu.
Thank you, sirs and ma'ams. Now we will break for lunch and reassemble at 2 p.m.